Well, good morning, everyone. I am Dr. Laura Lacher, and welcome to today's Medical Grand Rounds. As usual, we will get started with some logistics and reminders and then introductions for today's speaker. Be sure to join us next week as we host the Andy and Bev Hansel lectureship from the Providence Ethics Department, who will be giving the talk, Caring in Times of Cruelty, Moral Medicine for the Dolorous Healer. And as a second reminder, that will be our last session of the spring Grand Round season. So enjoy some fun time over the summer, and we will then resume Grand Rounds after Labor Day in September. But be sure to join us next week for that endowed lectureship. And now a few logistics. I am here at Providence St. Vincent and Souther Auditorium. And Grand Rounds is a joint effort between those of us here at St. Vincent's and Providence Portland Medical Center. We are often here live in person at 8 a.m. on Tuesdays, and we are occasionally live at Providence Portland at noon on Tuesdays. You can always join us virtually on Teams Live, and you can earn CME credit by being here in the room, by watching live virtual, or by watching a recording of the event. If you look at each week's Grand Rounds invite, it will let you know where we will be, and it also is the same link for the recording. I'll be monitoring the Q&A throughout today's session, so please feel free to post any questions or any comments, and I will hold those mostly until the end as time permits. And now I'm excited to introduce today's speaker. We are joined by Dr. Melissa Murphy, who is a practicing infectious disease specialist with the VA, with particular expertise in HIV care. She earned her medical degree at Chicago Med and then did both internal medicine residency and infectious disease fellowship at OHSU. Dr. Murphy has been serving as the HIV lead clinician for the VA for the state of Oregon since 2001. She has participated in both immunology and virology basic science research and was a primary investigator on several HIV clinical trials, including the START study and registrational drug trials for various antiretrovirals. Dr. Murphy served as the medical director for the Oregon AIDS Education Training Center from 2010 until 2023, and is currently a faculty member and clinical case consultant for the Regional AIDS Education Training Center office in Seattle. We're so delighted to learn from her expertise today.
Good morning, everyone. So I have no disclosures. So today's talk today is going to be essentially top 10 facts that every clinician should know about HIV in 2025. So normally, as Imran can say, I usually give a very esoteric talk to our HIV specialists in the area or infectious disease fellows, but I wanted today to give a very practical talk for things that you could use and would be important to know in clinical practice. I also wanted to try and focus, at least for the beginning and last HIV facts, for things that are really positive that have changed since I started doing HIV care, which was way back in 1997 when I was a lowly resident in the infectious disease clinic rotating through, particularly considering the news has been somewhat depressing as of late. So I wanted to have a few positive things. So I'm going to start with HIV fact 1, and that is that most patients diagnosed with HIV can now have a life expectancy that is almost as long as someone without HIV. And I think that's really important for folks who are doing primary care or general internal medicine to know for two main reasons. One, back in the day, a lot of people were anxious about doing HIV testing of patients because they were afraid, gosh, I don't want to tell someone they have HIV because back in the day, it was really a death sentence. And secondly, now that patients are actually living longer with HIV, sometimes we didn't really focus on the health maintenance and cancer screening later on that normally one would, because we figured they weren't going to live that long. But now we need to focus on those things when we treat HIV patients. So I wanted to just kind of give a little bit of an historical perspective on kind of the HIV epidemic. I like to wander new slides. So if we go back all the way. This is the natural history of untreated HIV infection. And this is data from the multi-AIDS cohort study, which was done out of Johns Hopkins in the 1980s before we had antiretroviral therapy. And in fact, they had banked these studies before we even had the PCR technology to look at viral loads. So if you notice, if someone acquires HIV, they actually don't have symptoms a lot of times until they're about 7 years into the infection. So a prolonged period of clinical latency, which is why HIV has been so successful as a virus, because of this prolonged period of clinical latency. But back in the day, when patients would present with HIV, be tested and diagnosed, you'll note that they really only had a few years to live. So HIV really was a death sentence in the 1980s when patients were diagnosed. Now, if you look at when we had the development of antiretrovirals, so in 1981, that was when the first AIDS cases were reported in the United States. We didn't even get the testing till like a year or two later. And the first antiretroviral, which was AZT, also known as idovudine, didn't come into existence in terms of treatment until 1987. But unfortunately, if you notice, the first several years of antiretroviral therapy were only nucleoside reverse transcriptase inhibitors, so all drugs from a single class. And when you give monotherapy, the virus gets resistance in about 6 months on average. And so the antiretroviral therapy did not actually impact the HIV death rate. So it wasn't until 1996. So the first protease inhibitor was sequinavir in 1995, but really the one that revolutionized antiretroviral therapy was the drug indinavir. The brand name was Crixivan back in 1996. That was the very first protease inhibitor that became available and allowed us to do what we now term HAART, or highly active antiretroviral therapy. In other words, giving 2 or 3 drugs, but definitely representing 2 drug classes to prevent the rapid emergence of resistance. So in 1996, that's when things really changed. And that's actually shortly after, or right around the time I started in the clinic, because I graduated from medical school and started my residency in 1996. So in 1996, the total life expectancy for a 20-year-old person with HIV was 39 years old. So a lot of you in the audience are young, and so if you think about that, that sounds terrible right now, but back in those days, it was actually pretty good. That was 19 years, which was a heck of a lot better than just a few years if you were diagnosed in the 80s. But by the time we hit 2013, the North American AIDS cohort study showed that a 20-year-old starting HIV therapy could actually expect to live to their early 70s, which is, to me, having done this a long time, is absolutely amazing. And a more recent study published in Lancet HIV in 2023 actually confirmed this finding, with an average life expectancy from 71 to 75 years old for a 20-year-old newly diagnosed with HIV in North America and Europe. So what changed between 1996 and 2013? Well, 2 major things. One was the introduction in 2007 of the integrase inhibitors, the first one being raltegravir, which are now the mainstay, the anchor drugs of our antiretroviral therapy. We also had the introduction of another new drug class. This is an entry inhibitor, Maraviroc, in 2007. The other thing that really was very important, and this is one thing that I want to demonstrate for all of you through this data, is the very great importance of doing HIV testing as routine primary care and internal medicine clinic. Because back in 1996, when I was doing this, all we did was targeted testing. So you would test someone for HIV if they had symptoms that you thought could be consistent with HIV, or if they fell in a group of patients who were at high risk for HIV. And back in those days, patients were getting diagnosed so much later. So you can all congratulate yourselves, because your testing of patients as part of primary care has really contributed to the increase in lifespan of HIV patients. And if you notice the slides, this is from that last paper that I was mentioning. If you look, and I'm going to just focus on the men, this slide is for women, but the general population remaining life expectancy at age 40 for the average male is 40.7 more years. And just to clarify, because this always confuses me, when you talk about US life expectancy, it's at birth. And for the United States, about 74 years old for men and 79 years old for women. But they have another set of data, which is important for those of us who are going to be retiring soon, to look at the life expectancy at age 40. So if you make it to age 40, you have an average of 40.7 more years. But if you look at this in terms of the HIV patients, and you can see that the one cohort they looked at were those folks who were diagnosed between 1996 and 2014, and those that began therapy after 2015. And the importance of the date of 2015 was the year that the START study, of which I was the PI for Oregon, so this was the strategic timing of antiretroviral therapy, came out. This said that every patient with HIV should immediately be started on antiretroviral therapy, irrespective of the CD4 count. Prior to 2015, the WHO and originally the DHHS guidelines would recommend that people be started on antiretroviral therapy only after their CD4 count rose above 350, which in hindsight was not the right decision, but it was made at the time because before we had those integrase inhibitors, again, the first being raltegravir in 2007, antiretroviral therapy had a lot of side effects. So if you look, the key point that I'm making from this slide is that if you look at the folks who actually have the higher CD4 counts, there's not a huge difference in terms of the lifespan compared to the average person. So again, the key point is that you want to be diagnosing people with HIV as early on in their infection as you possibly can. Because if you notice, the difference in life expectancy is much, much lower. If you look at these folks, for example, who are the MSM or heterosexual patients diagnosed with HIV who had CD4 counts less than 100, that life expectancy is going to be much lower. So my point partially in mentioning this was to just remember to incorporate HIV testing as part of primary care, because you will make a big difference in that patient's overall life expectancy and the quality of that life. Okay, so this leads into HIV Fact 2, which also makes me very happy, considering, as I said, when I started in 1997, we didn't have a lot of drugs, but there are now five antiretroviral drug classes with 5 or more different agents in each of these drug classes for the treatment of HIV, which is just amazing. And I've shown you this already, but look at kind of where we've come since 1996. And again, we have a lot more agents available. So if we look at the nucleoside reverse transcriptase inhibitor class, we actually haven't had a new drug there since tenofovir, which came out in October of 2001. And I should qualify, so the ones underlined and in green are the newest agents, so those that have come out in the last 7 years. So we're still getting additional drugs. In the non-nucleoside reverse transcriptase inhibitor class, we have the first generation, the second generation, and thankfully now a third generation and an RTI called doravirine, which has a slightly different resistance profile, which has been very helpful. The protease inhibitors, we haven't had a new drug in quite a while, but the integrase inhibitors, as I said, have really revolutionized antiretroviral therapy, and we now have the first generation raltegravir, elvitegravir, the second generation dolutegravir and bictegravir. Cabotegravir, I like to call generation 1.5 in terms of resistance, but it was the first injectable antiretroviral, which in combination with the drug rilpivirine allows for patients who really have problems taking oral medications to come in once every 2 months for an injection. So that has been another major impact in antiretroviral therapy. And then lastly, we have this drug class that I bet a lot of you have never even heard of these drugs. And these are all drugs, qualifies as the fusion entry inhibitor class. But the great thing about this drug class is that every single drug in this class has a different mechanism of action and therefore a different resistance profile. So there's no cross resistance. So for those HIV patients that, had major resistance because they were infected in the 80s, we now have options for them as well. So T20, hate that drug, never use it. It's the drug you'll never use because it has the lowest genetic barrier to resistance, because it is a fusion inhibitor and it works at the envelope. So I just list it there for continuity. Maraviroc, as I mentioned, came out in 2007. That is an entry inhibitor. I still occasionally use that drug to this day. Ibalizumab is actually, we have to have our own mAb in infectious diseases too, in HIV. Don't use that one because that is, that's a mAb that works right as the CD4 cell is entering, or excuse me, the HIV is entering the CD4 cell, the GP120 binding. But we don't use that too much. It's an every 2 weeks IV injection. We have fostemsavir, which is an attachment inhibitor. And then lastly, lenacapavir, which is the newest drug, which I'm going to talk about because I'm very excited about this drug as well. So HIV Fact 3, there are now multiple single tablet antiretroviral regimens that can be used alone for the first regimen, but can also be used in combination for patients with resistance mutations. And this is a key point because back in the day, if you had to be on what we used to call salvage therapy, so you had failed your first regimen or your second regimen, you were taking huge handfuls of pills multiple times a day. Now, because you can use the combination of single tablet regimens, you can actually have somebody who's on what used to be considered a salvage regimen that's on 2 pills once a day, which to me is also amazing. So I want to go through a little bit of the history because you may get patients that you're seeing in clinic that are on these medications and you're like, what the heck are these? So those of us who do HIV, if we're using a single drug, we're often referring to it by its drug name. But if we're using one of these combination pills, we often refer to it by its brand name. That's kind of the way we chat about these, and we all kind of know what they are. But just so you're aware, so Atripla was the very first single tablet regimen, and that was approved in 2006. And I can remember that. I can't believe it's 20 years ago, just about. So Atripla was the first one. It was NNRTI, or non-nucleoside reverse transcriptase inhibitor based, and it contained tenofovir in its old TDF formulation, emtricitabine, also known as FTC, and efavirenz. So you will have seen a lot of people who at some point were on Atripla, and a lot of people who don't want to get off Atripla because that was the first regimen that actually worked for them. Now, we actually had another NNRTI-based regimen come out in 2011. This was Complera, which is essentially the same as Atripla. It had tenofovir, emtricitabine, but the NNRTI rilpivirine in place of the efavirenz, which was useful because a lot of people had the CNS side effects from efavirenz, mostly bad dreams, some depression. So this one, the efavirenz, is a little bit more potent in terms of virologic efficacy. So I used to put people on Atripla, and if they didn't tolerate it, switch it to Complera. But then, shortly thereafter, they came out with Odefsey, which utilizes the TAF version of tenofovir, and the TAF version of tenofovir actually has a lower risk of kidney toxicity and bone mineral density loss. So really, the change now has been that the single tablet regimens that we use the most are actually the integrase inhibitor based. The very first one that came out was Stribild in 2012, which was tenofovir, emtricitabine, elvitegravir, and cobicistat. Now, the cobicistat was there as a boosting agent so that the elvitegravir could be dosed once a day, because the original raltegravir, which came out in 2007, as I mentioned, was a twice daily drug. And who wants to be on a twice daily drug when you can be on a once daily drug? But this drug, you won't see this too much anymore because it was immediately supplanted by the two single tablet regimens that are still to this day on our preferred regimen list, because dolutegravir and bictegravir, as second generation integrase inhibitors, have higher genetic barriers to resistance and don't require this particular drug for boosting. So as I mentioned, these are two of the first line treatments for HIV now, are these single tablet regimens. There's also some newer non-integrase inhibitor based single tablet regimen options. The first I list here is Simtuza. This is TAF with FTC and the protease inhibitor darunavir boosted with cobicistat. So as a PI, you're going to see more GI side effects. Then there's also Delstrigo, which I have been using a fair amount of. This is tenofovir in its old formulation TDF with 3TC. And then the NNRTI, which I mentioned is the newest in that class, called doravirine. And so it's going to have a little less GI side effects. And you might ask, well, geez, why did they co-formulate it with the old version? So you have to remember that a lot of these combinations utilize the fact that some of these older HIV meds have actually gone off patent. And this is part of why PrEP, for example, in its generic Truvada version is now so much cheaper, because TDF is no longer on patent and it can be combined with any other antiretroviral that a company makes. And so that's why we now have drugs like Delstrigo. So we sort of circle back to the NNRTI combination pill. We also have Juluca, which is the combination of rilpivirine and dolutegravir. This was the first 2-drug single tablet regimen that was FDA approved for use as a complete regimen in the US. So what we're looking at now are the single tablet regimen options with 2, not 3 active drugs. And that's why these 2 particular drugs are useful. This was actually FDA approved in 2017 for maintenance therapy after a patient had achieved virologic suppression. And this drug can be useful, and I like it for 2 reasons. One, it is the smallest of all of the single tablet regimens that are available, because rilpivirine and dolutegravir by themselves are 2 of the smallest pills that we have. So it comes in handy if you have somebody with swallowing issues. I had a patient, unfortunately, with esophageal cancer. The other reason I like this drug is that if you have a patient who's on Juluca, they can just be streamlined transition to the Cabenuva, because you've essentially already done that lead-in by using Juluca. In fact, I don't actually do the oral lead-in anymore. I just do Juluca. The other one in this class is Dovato, which is the combination of 3TC with dolutegravir. This was FDA approved in April of 2019. It is actually recommended for first-line therapy in patients without hepatitis B and with a viral load less than 500,000 copies per ml, because again, you're using 2 drugs instead of just 1. And that's a question. I can see you're shaking your head that some of us have in HIV care that we're a little bit anxious about going right to 2-drug therapy, but we'll save that for the end. Okay, so now I'm going to talk about lenacapavir, which is one thing that is also very exciting to me. And this is now an antiretroviral that can be given as an injection every 6 months, 6 months, for both treatment and prevention of HIV. And it does not have cross-resistance with any of the other antiretrovirals. So those of us in the HIV field have been very excited by this drug. So lenacapavir is a first-in-class HIV capsid inhibitor that was approved in December 2022 for those who cannot be successfully treated with other antiretroviral treatments due to resistance, intolerance, or safety concerns. So if you look at the HIV anatomy, here's a little GP120 poking out here, and this is the capsid. And within the capsid, so people kind of talk about this as the reaction container for reverse transcription, because it contains the HIV RNA and the reverse transcriptase enzyme. So it actually traffics through the cytosol of the CD4 cell and shields it from the cell's DNA sensors to allow it to arrive in the nucleus, which is here for integration. So again, this is where the integrase inhibitors work. But so this drug actually targets multiple steps in the HIV replication cycle process. So it's very cool in that regard. The other reason, and again, my bent is I focus on antiretroviral resistance. That is my specialty. The reason I love it is that there is no cross resistance. So the capsid domain of HIV is in the GAG protein. So if you look at the genomic organization of HIV, we've essentially got 3 different sections. We've got GAG, polymerase, and envelope. So polymerase is where all of the drugs that you're used to seeing for HIV work. So the reverse transcriptase, which is where the nucleoside reverse transcriptase inhibitors and non-nucleoside reverse transcriptase inhibitors work. protease, so the protease inhibitor, and then integrase, the integrase inhibitors. And as I mentioned, our probably least useful drug that we have, Fusion, also known as Inferritide or T20, works at the envelope. And envelope is not a fun place to have your drugs work because it mutates quite rapidly. And it's part of the reason that we have not been successful in having an HIV vaccine. But if you look at GAG, this protein is under strong pressure to conserve functional roles in viral assembly, maturation, uncoating, and nuclear import. Therefore, it's well conserved. You don't have pre-existing mutations. So every single patient that I have that I've been following for decades now that had, CD4 counts of less than 10 is susceptible to this drug. So I now have 2 patients on this drug who've done well with it. I made a copy. I took a couple pictures in clinic for those of you who might be curious as to what this kit looks like. Here is the kit for injection. So, but the downside of this drug is it is very expensive. So on the open market, it is $42,000 per year. At the VA, we get a little bit better deal because we have federal pricing. But I was like, wow, I'm holding in my hand this kit that cost me more than my first car. So you may not see this in use a ton because it's very expensive. And the same reason in terms of prep for that reason. Okay, I'm doing okay on time. So HIV fact number 5. Low-level HIV viremia does not equal treatment failure of antiretroviral regimen. And I put this in because this is a point of confusion. I get patients panicking now that we're sending lab letters out that, oh my God, my viral load's 100. Oh my God, what's going to happen? Or the primary care providers reaching out and saying, the patient has a detectable viral load. What do I do? Well, so I try not to get too worried about these things, and that's why I want to give you some perspective. So low-level viremia, first of all, not everybody agrees on the definition. The people in HIV that are the prevention specialists like to use the definition of 2 to 200 copies per ml, 20 to 200 copies per ml. And those of us who've been doing this a long time or focused on resistance like to use the definition of 20 to 500 copies per ml. So you have to have the perspective that the original assays that we use to look at HIV viral load. So when I started in the clinic in 1997, the lower limit of the viral load for limit of detection was 500 copies per milliliter of blood. It rapidly went down to 400, and we sat at 400 for a decade. So as I explained to the patient, you could have been sitting at 399 for 10 years, and your viral load would have been deemed undetectable. Now, at least at the VA, we have this fancy schmancy TACMan machine that goes all the way down to 20 copies per milliliter of blood, which initially I was very excited by, but now as with the low-level viremia, sometimes I think it causes more angst than anything else. So that's why I kind of keep that in perspective for the 500 copies. I will also mention that the 500 copies is the lowest level that you can actually do resistance testing on. And since I won't change a regimen for virologic failure, until I get resistance testing, this number is important. So I don't freak out when I get low-level viremia. So you'll also hear the term viral blip, which in essence is interchangeable. So the definition of viral blip is essentially when the viral load temporarily rises to a detectable level after previously being undetectable. And this is due usually to latently infected cells essentially spitting out virus. And it's usually seen in patients who started with a high viral load, diagnosed earlier, and so they seeded these latent reservoirs. And this can occur with immune activation due to infection, like a viral URI, or immunization. And in fact, we saw a lot of viral blips in the context of COVID. Every time I gave somebody a COVID vaccine, boom, you get low-level viremia. And I was like, oh my God, the viral load's detectable. It hasn't been detectable in a year. And I was like, it's okay. The COVID vaccine is highly immunogenic. You're just having a viral blip. You've had HIV for 20 years. It's okay. So this is why I wanted to make this point, just so you don't have the angst if you see this in one of the HIV patients. If you see a viral blip or that viral load, all you have to do is repeat it. Because if we look at the definition of virologic failure is the inability to achieve or maintain HIV plasma viral load less than 200 copies after 6 months of continuous antiretroviral therapy. But the key point is that lab results must be confirmed with repeat testing before a final assessment of virologic failure is made. So if I have somebody with a viral blip or low-level viremia, I simply repeat the viral load. Well, first, I talk to the patient and go, did you get a vaccine? Or did you go on vacation and forget your antiretrovirals at home? You'd be surprised how often that happens. So more often than not, there's a simple explanation rather than virologic failure for the regimens that we have now, because the regimens we have now have such excellent genetic barriers to resistance compared to what we had before. So my message here is, if in doubt, just repeat it. I usually do it in about 6 weeks, plus or minus a couple weeks, just depending on kind of what the story is when I talk to the patient. Okay, I am halfway. Oh, good. I'm on time. Okay, HIV Facts 6. HIV infection increases cardiovascular risk and so should be considered a cardiac risk factor. So I'm pretty sure all of you in the audience are all over the ASCVD risk factors. And so this is why this particular study to me was very interesting. I'm not going to go over this in detail because I can't squish all 10 facts if I do that. But this was the Reprieve study that just came out a couple of years ago. And this was a randomized prospective trial of persons living with HIV aged 40 to 75 on stable antiretroviral therapy. But the key point in the study is that they looked at patients who had low to moderate risk in terms of cardiovascular events, not the people that you normally look at, which would be moderate to high risk. And they were given either pitavastatin or placebo. And there were, almost 4,000 people in each group. So not surprising to any of us who do any primary care or internal medicine, the statin reduced the incidence of cardiovascular events. But what was interesting in this particular study was the fact that it seemed to be beneficial not just for the patients with a higher traditional ASCVD risk score, but rather some of the lower ones as well. And the number needed to treat for, just the 2.5 to 5 was actually relatively low. So the reason I mention this is that the DHHS guidelines for people living with HIV was updated last year, so that for people living with HIV age 40 to 75 years old who have low to intermediate 10-year ASCVD risk, they recommend initiating at least moderate to intensity statin therapy with either pitavastatin 4 milligrams, atorvastatin 20, or rosuvastatin 10. And, the last time we looked at this, we were following essentially what you would do normally for everybody else, which the guidelines would be, 7.5. So this is saying all the way down to 5. So I've kind of taken this to say, hey, I'm going to count HIV as its own cardiac risk factor the same way I would count diabetes for a patient. So I used to be, you can wait to start your statin. Now I'm like highly aggressive. You want to start a statin? I think you should start a statin. Maybe you should start a statin until they eventually give in. Because I will have to say, over the last 20 some years, I am the PCP for many of the HIV patients at the VA. I've seen a lot of folks having what I would consider premature cardiac events based on their age, or what I thought, or when you calculate out the ASCVD risk factor. So I just wanted to put that out there to err on the side of starting the statin or upping the dose on the statin for these patients. But with one caveat, and that brings me to HIV Facts 7. And this is one of the biggest mistakes that I see made in patients that I've shared with other providers, or maybe get community care on the outside and don't realize what antiretrovirals a patient is on. The HIV protease inhibitors increase the statin levels. And the most common protease inhibitor that you will see used now is Prescobix, which is the combination of darunavir and cobicistat. You also, as I mentioned, have Simtuza, which is the tenofovir FTC with the darunavir cobicistat. This is the most common one you see. But if you co-administer Prescobix with atorvastatin, just 10 milligrams, the atorvastatin AUC and Cmax are increased by 290% and 319%, respectively, due to inhibition of the CYP3A4 and other enzymes. So that's a huge increase. And a daily dose of 40 milligrams is the dose not to be exceeded. So if you have a patient and you're like, oh, I've better bump up the dose to 80, make sure they're not on a protease inhibitor. And just as an aside, so the US product label for Prescovic states not to exceed atorvastatin 20. But if you go to the University of Liverpool HIV drug-drug interactions website, they actually use, say, a dose of 40 milligrams is okay. And I got this from our pharmacist, and I have actually done this on an HIV patient who has had an MI, and I was like, I want to push it up a little more. It works okay. And just a plug for this particular website, if you have not seen it, this is one of my favorite drug-drug interaction websites. It also, because it has one specific for HIV, and it had one also specific for COVID. We're not prescribing as much Paxlovid, but back in the day, I was like, oh, thank God for this website. So if you haven't used this, check that one out. Okay, I'm doing okay time-wise. HIV Fact 8. And this is another really important one for those of you who are doing primary care and manage diabetes. And that is that second generation integrase inhibitors. What I mean by that are the bictegravir and Biktarvy and the dolutegravir and Triumeq lead to a reduction in insulin sensitivity, which in turn can lead to higher blood sugars and weight gain. And this phenomenon is most pronounced based on many of the ACTG, the AIDS clinical trials groups, in patients who are African American ethnicity, women, and those over the age of 60. Those have the most pronounced alteration in that insulin sensitivity. So I'm going to start with, to share this with you, a cautionary tale. And I'm going to take a sip of water. So these are two cautionary tales of patients that I saw in clinic. So the first is a 61-year-old white male with HIV, hypertension, hyperlipidemia, and diet-controlled diabetes. Now, this gentleman had been infected with HIV in the 1980s. So he's had the regimen swapped around the drugs. So he was on a weird regimen. So he was on a bacavir lamivudine, also known as Epsicom, with old tenofovir with once daily nevirapine. So I thought, you know what, I'm going to update his regimen. I'm going to make it simpler for him to take, decrease his pill burden, increase the genetic barrier to resistance. I want to get him off the abacavir because there is some data to suggest at this point that abacavir may increase cardiovascular risk. And I want to get him off the old formulation of tenofovir, as hypertension and diabetes increase the renal toxicity risk for tenofovir. So I switched him to Odefsey, which, as I've shown you, is TAF with FTC rilpivirine, 1 tablet once a day, and dolutegravir standalone 50 milligrams once a day. So as is often the case in medicine, no good deed goes unpunished. And his hemoglobin A1C increased from 6.7 to 10.3. And again, he was over 60 years old, so an older gentleman. And he is not the only patient that I had this happen in. But again, as I mentioned, he went, this is key, he went from an NNRTI to an integrase inhibitor, and he went from the old version of tenofovir to the new version of tenofovir. File that away. I'm going to show you some slides in a sec. The cautionary tale number 2. Now, this was a younger guy, 44 years old, but he was African American, as I mentioned, higher risk of the change in insulin sensitivity. Now, he had HIV, asthma, hyperlipidemia. He just left active duty after 22 years in the Army. He'd been diagnosed with HIV in 2001 and started on AZT 3TC efavirenz. That was the standard regimen at the turn of the century before we had ATRIPLA. Pretty much everybody who was on this then got switched to ATRIPLA, the tenofovir, emtricitabine, efavirenz in 2006 when this became available to decrease pill burden. Now, this gentleman was changed to the Genvoya in 2016, which, as I told you, was the first integrase inhibitor regimen. It was a single tablet regimen to get off the old formulation of tenofovir. And there was a question in the chart that efavirenz was worsening his mood. So he came to me in about 2018. He moved here from Arizona. And I decided to update his regimen and change him to Biktarvy in 2019. And by doing that, increase the genetic barrier to resistance, because again, this is a first generation integrase inhibitor. Bictegravir is a second, and also to get the patient off cobecistat, because the cobecistat contributes to the hyperlipidemia. He had familial hyperlipidemia, and because of the drug-drug interaction. So again, he had asthma, and they wanted to put him in pulmonary on a steroid inhaler. So it's like, okay, I'm just going to get him off of the Genvoya, put him on Biktarvy. And again, I put this in just because this literally follows the timeline. His antiretroviral history follows the timeline. A triplet 2006, the Stribild shortly thereafter, and then the Biktarvy. So about 2 years after switching from Genvoya to Biktarvy, the patient had gained 27 pounds from baseline weight. And so I was like, it's COVID weight. Everybody's gained weight during COVID. But he swore up and down that he had no change in his diet, no change in exercise. He still was working out regularly. I made him come in so I could look at him and see, okay, this guy is still working out, because he was very buff. He worked out constantly. No new medications, no new supplements. He was completely convinced that it was the new antiretroviral combination and requested to switch. So I'm going to take a poll. How many people in the audience would change this patient's antiretroviral regimen? Okay, and how many would not change? And how many are undecided? Okay, that's fair. So you actually represent all of the HIV providers as well, because when I've asked this question before, that's the same response I get, and there is no great agreement on this. But I want to show you a little bit of data which prompted me to make a decision on this. So this is the NA Accord study. This is a huge cohort study that was done of 24,000 antiretroviral naive patients initiating antiretroviral therapy between January 2007 and December 2016. And they had varying regimens because, again, this was over a long period of time. And what you saw in this particular study, and bear in mind this is in kilograms, I have to in my brain always switch that over to pounds, but clearly the patients who were on an integrase inhibitor-based regimen gained the most weight by year 5, so 6 kilograms, which is roughly 13 pounds. That's a fair amount of weight. Now, when you start somebody on HIV therapy, if the CD4 count's low, you assume they're going to gain a little weight, and that's return to normal health. So that's usually, 2, 3, 4 kilos. It's not usually like continuing up there. So 13 pounds is a fair amount, because again, a lot of the people in this cohort did have higher CD4 counts. And then if you look at the specific integrase inhibitor, notice that the first generations have much less. And in fact, the elvitegravir, which was what he'd been on before, had much less in terms of weight gain compared to the second gen integrase inhibitor, dolutegravir. And bictegravir is essentially related to that and about the same. Now, here's some more data if you're not quite convinced yet. This is the pooled analyses of weight gain across randomized phase 3 clinical trials of first-line antiretroviral initiation between 2003 and 2015. So another 5,680 patients amongst these studies. So in this one, again, you look at the same thing. The integrase inhibitors have more weight gain over time compared to the protease inhibitor or NNRTI-based regimens. And if you look at the integrase inhibitors, the elvitegravir cobecistat is down here, and the second generation integrase inhibitors are up here. Now, the other interesting point is this is not the only drug in the regimen. What about the NRTI backbone? So if you look here, this compares the NRTIs, and notice that TAF, tenofovir alafenamide version of tenofovir, actually has the most weight gain compared to the older antiretrovirals, which incidentally, this is the same order of mitochondrial toxicity. So this has the least mitochondrial toxicity, and this has the most. So I think some of the older NRTIs that we were using were actually preventing the emergence of some of this metabolic toxicity through their mitochondrial toxicity. So when we started using more TAF and then added in the second generation integrase inhibitors, that's why we're seeing this now. So this is the advanced study, which I thought was interesting because this one was the most pronounced. This was actually done in South Africa. But you notice the median weight gain from the old version, the atriplo, which was the first drug he was on, was only 2 kilograms from baseline at week 96. But the TAF FTC second generation INSTI was 8. So you see the data is actually quite consistent. It was most pronounced in this particular study, which in the interest of time, I'm going to skip the data. But the weight changes did persist all the way up to week 192. And if you look at the folks in the TAF dolutegravir arm, 15% ended up developing metabolic syndrome versus only 7% in the older version arm. Okay, so for this particular patient, I went ahead and changed him from Biktarvy to Delstrigo, and that was why I want to make sure everybody knew what Delstrigo was before I talked about this. That is the old version of tenofovir, 3-TC, and doravirine. And after I made this change, the patient lost 15 pounds in 6 months, 20 pounds in 12 months, 25 pounds in 18 months. So to me, that was essentially kind of proof of concept that, yeah, this was the right thing to do. So he continues to eat healthy and exercise more. And interestingly, his LDL, I also started him on a statin. When I got him, he was not on a statin. He should have been on a statin. His LDL was 205. So I put him just on a low dose because of originally the interaction with the cobecistat in the Genvoya, and his LDL decreased from 205 to 89 with just 2.5 milligrams of rosuvastatin. And I had to make this one point because I find this fascinating. This is from the Drive Forward study, which was one of the registrational trials for doravirine, that when you compared it to the boosted darunavir, with which we saw an increase in the LDL over time, you actually saw a decrease in the LDL cholesterol from baseline at week 48. So I actually think he benefited from not just the rosuvastatin, but the doravirine, which makes me like this drug even more, I guess is my point. Okay, I only have a few minutes, so I'm going to cruise through these fast. Fact 9, generic TDF FTC is the first line choice for PrEP in the vast majority of patients at risk for HIV. And Imran, you gave a talk on PrEP recently, right? Okay, so I'm not going to go through this too much, but I put this in there, and here are the current options for PrEP because I'm so sick and tired of seeing the commercials that keep saying that the injectable form of PrEP is superior. Well, the reality is it's only superior if the patients aren't taking the type of PrEP that they're assigned. And I just want to point out just a few quick things. The cost of individualization of PrEP is huge. So generic PrEP, if we average it, when I did this slide, it was about $30 a month. That's $360 a year. But injectable cabotegravir, abbreviated CAB here, is $15,450 a year. It's ridiculously expensive, as is the TAF FTC Descovy option when I looked at it, 17 grand a year. And as I mentioned, the lenacapavir option, also not cheap, 42 grand a year. So in this study, I won't go through this. I'm guessing you already went through this, but I just wanted to point out this was the registrational trial for using Apretude or injectable cabotegravir for PrEP. And they stopped the study because of the fact that they were seeing a higher incidence of HIV with the oral version, but that's essentially because the patients in the oral arm were not taking the medication. So if you don't take it, it doesn't work. This was a randomized, double-blind, placebo-controlled trial that was an intention to treat analysis. And so the patients who were on the Truvada pill arm as the active drug were still getting injections that hurt, and they probably figured they were on it. So if you look at this, there were 37 of the 39 infections and the TDF FTC arm are explained by suboptimal adherence. So if you actually compare that to, I'm going to skip this, the cabotegravir arm, there were actually more patients in the cabotegravir arm that ended up that were taking the medication. So comparing only the fully adherent patients, you actually had more infections in the cabotegravir arm and more resistance in the cabotegravir arm. And if you're interested in this, Stephanie can give you the PDF of these slides so that you can look at it. But that's the upshot of that. And I also want to point out, this is a key finding, that PrEP efficacy with varying levels of adherence in the IPREX study, which was the big PrEP study, that the patients don't have to be perfect. So sometimes they'll come in and they'll ask for the injectable agent. They're like, I'm pretty sure I'm going to forget 1 or 2 of my pills a week. That's actually not going to lead to HIV, because if you look at the study, if the patients got down 4 to 7 of the tabs a week, they actually did not acquire HIV. And this is kind of proof of concept for the 411 or on-demand PrEP, which if you think about it, we call it, 211, 4 total. That's 4 total tabs. So people do not get HIV if they can get down 4 of the tenofovir pills a week. So that is my point. PrEP is going to be amazing in terms of an intervention. Now that it is generic, we can get so many more people on it to prevent HIV. Okay, and I know you talked about this, so I'm going to go to fact 10 because I'm running out of time. And I wanted to end with something that's really positive, and that is that patients with an undetectable HIV viral load cannot transmit HIV to others. In other words, undetectable equals untransmittable. And to those of us who've been doing this a long time, this is really amazing. And I have to say, I was very skeptical about this. I was like, I'm an infectious disease doctor. I never like to say never. But the data really supports it. And I love this table that I made, because this really is like, boom. So this is the studies that were used to come up with the U equals U recommendation. There were 4 studies, the HPTN 052, Partners 1 and 2, and Opposites Attract, that had male and female couples, MSM couples, no PrEP use, and there were 0 link transmissions. So I went to a lecture at the Retrovirus conference, and he said, it was a gentleman from the Swiss HIV cohort, and he's like, all right, I know all of you guys are highly skeptical about this. I'm going to prove this point to you with math. So he put up all of those 4 slides, and essentially there were 0 transmissions in 4,063 couple years of follow-up when all of the results from all 4 of the studies were combined. So if the patient who's the HIV positive partner has an undetectable viral load and maintains that undetectable viral load, they are not going to transmit HIV. So the question that I always get asked is, how low is undetectable? So because they actually used less than 200 was the definition that the CDC used, that was based on the assay in Partner 1 and 2, which they used for the study. And then 6 months minimum on combination antiretroviral therapy. But that is a very positive thing for those of us who've been doing it a long time. And, I didn't think that made as much of a difference, but when you talk to the patients, that is so meaningful for them that they think, oh my God, I'm not going to transmit HIV. So again, the most 2 positive things that I want to get to you are that the patients, if we diagnose them early with their HIV, it's a chronic medical condition. They can live into their 70s. And if we can maintain virologic suppression, they can essentially live a normal life and not have to worry about transmitting HIV to any sexual partners, family members, or anything. So HIV has really come a long way since when I started in the clinic in 1997. So I'm going to stop there and take questions, but I'll leave this on my side. And only a few minutes over.
Wow, thank you so much, Dr. Murphy. Very exciting. Any questions here in the room? Well, people are thinking on that. I will start with one. So thanks so much about talking about the reality of people going on vacation and missing doses of medication. So now talking about patients who are on treatment for HIV as opposed to PrEP. Can you talk a little bit about sort of your threshold of worry for missed doses, and if anything different needs to be done if, say, oh, there's a longer period of missing their drug.
Do you mean both HIV and PrEP?
No, HIV treatment.
Oh, HIV treatment. Okay. So I used to get very, very anxious about this particular phenomenon, but I will have to say it depends on the regimen. So the patients who are on the regimens that have high genetic barriers to resistance, I have not had anybody have virologic breakthrough that did that exact phenomenon. I forgot my meds for 2 weeks because the virus is so suppressed. They may end up with a little bit of a viral blip, and then I repeat it again. The patient who I worry about is not the one who stopped and then restarted, was adherent before they stopped, has been adherent after they started, is the person who comes in and was like, hey, you know what? I've started shooting up meth or heroin or whatever the case may be. I think I've been taking about 50% of my doses for the last 2 months. Now that patient is the one who I worry about because that's the sweet spot for the virus to get resistant. So remember, you have to think of it as Darwinian, like selection pressure. So if there's drug there and it's present, it will select for the resistance mutation. So not enough drug there to kill the virus, but enough for it to notice it. If they've completely not been taking it, then the selection pressure is taken away. The virus wants to be in its wild type state. So in that instance, when someone comes in and they have low level viremia, in that case, as soon as the viral load hits about 1,000, and I will repeat it if it's in the low 100s about 3-4 weeks later to say, okay, I really encourage them to really try hard for adherence and see, does it go up or does it go down? If it goes down with improved adherence, that was more than likely the viral blip or low level viremia that we were talking about. But if it continues to rise and they're telling me that they're doing a much better job of taking the medication, then I will go ahead and do resistance testing. And again, if the viral load is over 1,000, you can definitely get the specimen to amplify for resistance testing. If it's 500, you got a 50-50 chance. Back in the day, when we didn't have as many options available, when I had someone coming in saying, I'm only taking this like half the time, I was like, okay, I do not want to select for resistance. So back in those times, I often would put somebody on antiretroviral drug holiday. I hate that term. But I would do it so that they could get their substance abuse treated so that they weren't then selecting for resistance mutations that could come back and bite them later, especially back in the day when the patient was quite young and we didn't have as many options as we do now.
Great, thank you.
Thanks so much for this. I love the good news. It seems really complicated, HIV care today. And I know that there's, ID docs,
yes.
Maybe not enough ID docs doing this. And then there's primary care docs that get special training in HIV. Yes. And I'm thinking that those of us who don't have primary care training in HIV or a significant sort of keeping up with it, maybe best not to be treading in this area. Would you agree?
So I think it depends. We have a lot of folks, like, for example, at the VA that live literally in the middle of nowhere. And so they come to see us maybe like once a year. And so I think what the primary care folks can do is maybe just get the labs for us. And that is essentially a viral load once every 6 months and a CD4 count once a year. But the second that viral load goes up, it doesn't say undetectable or LLOQ, less than the lower limit of quantitation. Yes, please have somebody that has some expertise in HIV medicine figuring out what to do with those patients. So I think the role of the primary care provider is just to assist us in getting the labs and then saying, hey, something's wrong, we need some help. You should not be managing antiretroviral therapy. It is very complicated. And it needs to be done correctly, because I used to see back in the day, people would just shove on another drug to a failing regimen, and that is the way you select for resistance, and we definitely don't want that. So yes, it should be the HIV medications themselves should be managed by somebody who has experience with HIV. But please help us and get the labs. We appreciate that.
Great. Thank you, Dr. Murphy. I just want to call out some comments online, commenting on a great presentation and review, and I think those of us in the room agree. So 9 o'clock, we really appreciate your work in this space.
Thanks for having me.